I'd like to talk to you today about standards, both national standards and international standards. And here in Canada, we have, well, I call them a national treasure. The Canadian Standards Association produces about 2,000 national standards that govern everything from, soup to nuts here. So construction industry, electrical, gas, et cetera, and including medical. So we have about 200 standards that include things in healthcare and a number of them that cover infrastructure in healthcare, which is really important. So I've been involved with CSA standards for over 30 years now, and with ISO standards as well for about 20 years, primarily in anesthesia and respiratory. And I can tell you that standards are often referenced into legislation, laws, regulations, and even when they're not, they generally form the basis for a lot of practice and guidelines. So I've been working, over the years with a number of other people to try and move Canada towards safer environments, particularly in healthcare, primarily through standards. Here in the US, we have, a similar group of standards, and then ISO
Getting,
has their
she
group
cannot
of
get
standards.
in. So you need one of the original.
Sorry, Barry. We had a hot mic. I do hear
Sorry,
that.
can everybody see my screen okay?
We can.
Yeah,
You
okay.
go ahead. Go ahead,
Yeah,
please. Thank you.
yeah, and so short of standards, we're going to have to rely on just guidelines that are produced out of thin air quite often from a lot of organizations. So when it comes to public health, for example, a lot of people follow the World Health Organization lead. A lot of that, for example, is done here in Canada, where Public Health Agency of Canada and IPAC Canada, et cetera, tend to generally follow WHO. But more and more, we're moving things into CSA national standards where we've got more robust data, more robust science, more robust everything, consensus-based process, et cetera, to develop better guidelines than what we would have coming from WHO. And in the US, we have CDC, the HICPAC group determines in the past has determined contact precautions, standard precautions, et cetera, in healthcare. And so they have a similar type of a process there, although a lot of that is interrupted right now. When those standards don't match what we need to double down and improve them or develop new standards, additional ones. I've been involved with initiating a lot of new standards here in Canada over the years, and then adding content to existing ones. And a lot of that I think can be done with other groups in other countries can follow that type of a lead as well. I know it's made a real difference here. So, for example, in Canada now, you can't build a new hospital without having single patient rooms and certain types of sinks. And you can't do it without building in technologies or at least evaluating the technologies in the design phase to prevent hospital-acquired infections moving forward. And that wouldn't exist, without those standards. And it's made a tremendous difference to the hospital-acquired infection rate here. So here are a number of different technologies that can be used to reduce the exposure to pathogens in air and on surfaces, et cetera, that we support here at Chair. And we try to make sure that those are now included into those national standards. Here's a group of technologies that I've been personally involved with over a number of years and how they fit into different standards over the years. Big categories really are continuous air disinfection, automated room disinfection. So air and surfaces like bathrooms, for example, every time you go in and out, they're automatically disinfected. High touch surfaces or important surfaces around patients and self-cleaning, self-disinfecting sinks. So those four categories are the big ones that can really change the game in new infrastructure. All of these the group of standards really that you need for healthcare, you need the design, cleaning, disinfection, respirator use in healthcare, and cost benefit of disease protection. So if you do it the old way versus doing it a new way and looking at technologies, et cetera, what is going to be the difference in the impact coming out? And then we also need a new standard for bioaerosol respirators for the public that for disease protection specific as opposed to using the particulate respirators we have today that would also stop disease transmission.
30
When you're
seconds,
developing
Barry.
standards, you need to work in a consensus-based manner, pull in a number of people, with different expertise, different perspectives, et cetera. go through a process where you develop the draft standard, send it out for public review, make sure you look at all that input and as much input from stakeholders as you can, and then follow an accredited process where available. Here in Canada, it's our standards development organizations are accredited by Standards Council of Canada. The elements that really need to go into your standards, obviously for disease protection, precautionary principle, you need to make them as objectives based as possible. So you're stating what objective you're trying to achieve to allow new ways of doing things, new technologies, etc. Simple, clear, easy guidance, and very informative annexes that either explain the text that you put in there or provide some supplement and direction for future. Standards should really lead rather than follow. And so here on our healthcare facility design standards, we're asking for people to have expertise in engineered infection prevention right at the design stage to use and consider the latest emerging technologies, et cetera. And we're specifically looking for a 90 to 99% reduction in exposure to pathogens. Very important, this cost benefit analysis piece here, because when you go to build a hospital, it might cost billions of dollars to build that hospital, but it costs many more billions of dollars to operate that hospital. And if we have a standardized format of looking at what an intervention will do over the, say, for example, 30-year lifespan of the building, look at that cost benefit analysis, it really becomes a no-brainer that you need to do things in a much better way than what we've been doing in the past. So we really promote the idea of universal airborne protection, which are 6 air changes an hour, for example, is just a start of clearing the room from odors and some other things. It's really not great for disease protection with mixed ventilation. So you really need to use upper air UV, far UV, displacement ventilation, or some type of other source control like extraction ventilation to supplement that to get the result that you're looking for. Same thing with cleaning and disinfection. You need that expertise, you need the stated reduction in exposure outcome, and you need the cost benefit analysis. Same thing for respirators. And with respirators, we really need to start focusing on broadening the scope. So it's not just occupational health and safety. It's not just adults that we're writing our standards for. It's for everybody. And it's specific for disease protection, not particulate capture that also happens to capture bioaerosols. Make sure that they're easy breathing, easy sealing, environmentally friendly, et cetera. And so the whole crux of the cost benefit analysis has to do with the performance of the patients. And so if you get an infection in a hospital, you're typically there for an extra week. If it's multi-drug resistant, you're there for an extra 2 weeks. And if you're there, yeah. Anyway, so that extra time that you're there is, very expensive, and it ties up beds. So about 20% of the beds here in Canada, there are 95,000 beds, are tied up because people are in them because they had to stay an extra week or two or longer because they got an infection in that hospital that they didn't come in with. So that backs up everything in emergency departments, and we have, overcrowding, et cetera, et cetera. And we have long wait lists to get procedures, et cetera, because 20% of our beds are not available because we've infected people when they come into the hospital. We have a subgroup here at WHN where we're looking at a way to standardize how we can do cost benefit analysis going forward at different interventions. And that's looking at the impact on the facility itself when you go to build it, or if you're going to be cleaning disinfectant, the operations within it, and most importantly, what are the social impacts of infecting people, and what are those downstream costs, and how can those be captured, or that savings be captured? And so it's a return on investment. It's not so much a cost benefit, but an investment benefit analysis that we need to do. And what we're trying to do here is justify
Gary,
a
I think we're
national.
getting behind schedule. I'm sorry to interrupt.
I'm so sorry. Okay. That my last point was, if you look at it across the whole country, prevention is really cheap. We spent $19 billion responding immediately to the pandemic, but our long-term costs are trillions of dollars. And if we'd spent $19 billion up front to prevent things following some national standards, we could have protected all sectors of the economy and saved those trillions of dollars downstream. Sorry. Thank you very much.